Again, thanks everybody for joining. We've got about 3-4 more minutes. We'll let people get on board and then we'll get started. Thanks for joining us this afternoon. And just a quick reminder, if you're not speaking, if you'll make sure that you're on mute. Much appreciated. Good afternoon, everyone. We're going to go ahead and start the recording. Go ahead and get started. I've got 1:59, so appreciate you guys joining us. It is August the 6th, and this is our August Maternal webinar series for Georgia Perinatal Quality Collaborative. The title of our presentation today is Addressing the Cardiovascular Contribution to Maternal Mortality. Thanks so much again for joining us. Before we get started, just a few housekeeping items. Please make sure your lines are muted during the webinar to avoid any interruptions. Just a reminder that this webinar and past webinars are housed on the Georgia PQC website for review at your convenience. They're located under the Maternal tab. They're also available on DPH's YouTube channel. We should have a few minutes for questions at the end of the presentation. Feel free to type any questions into the chat. If for some reason we run out of time and you have a question, feel free to email that to us at georgiapqc@dph.ga.gov and we will get back to you. Just a quick reminder, we have, many of you have new staff or leads or champions, and if we need to update our listserv, so that you're receiving those updates related to GAP QC activities, please feel free to email me at amy.mock, M-O-C-K, at dph.ga.gov. I'll be happy to add any of your new staff or make any revisions that need to be made for updates. Quick reminder that Jennifer Bolin is the Women's Health Improvement Advisor. She's working full-time to provide guidance, coaching, and technical support whenever possible. Feel free to reach out to Jennifer and utilize her experience and expertise to assist with your quality improvement work. And if your facility is interested in joining the Cardiac Conditions and Obstetric Care Initiative, please reach out to Jennifer. We are currently recruiting for Wave 3, which is slated to open and begin January of 2025. Jennifer and I would love the opportunity to set up a call with you and your team and walk you through any questions you may have and provide some additional resources. Just an update, we currently have 16 actively engaged birthing hospitals with a goal of 28. If you're currently in the learning cohort but are interested in transitioning to an active team, we'd love the opportunity to assist with that as well. We always like to provide and share just a few resources and educational opportunities, so we wanted to go through those really quick. Our next Georgia PQC maternal webinar is scheduled for Tuesday, September the 3rd at 2 p.m. with Dr. Deirdre Mattina from Ohio as the guest speaker. She'll talk about cardiovascular risk beyond birth and team-based approaches to addressing cardioobstetrics. We've officially launched and gone live with our new data platform, Simple QI. If you're having any issues accessing the site, creating your homepage, or assigning roles, please let Jennifer know as soon as possible. 2024 Q2 data submission for April through June is now due. We extended the deadline for data submission to this Friday, August the 9th, to give time for teams to get acclimated to Simple QI. Again, if you need any help with data submission, please reach out to one of us. We're happy to help. We anticipate the new platform will be much easier for you and will allow you to see real-time data as you enter it into the system. Oops, I advanced that too quickly. Let me move back. AIM has launched their Severe Maternal Morbidity Review Form Learning Sprint with webinars scheduled for August the 15th, 22nd, and 29th at 12 noon. After the webinar today, I'll send out a link as a follow-up if you're interested in joining and registering for any of those. I've also placed the link on the screen here if you'd like to register for those. The Maternal Health Learning and Innovative Center is hosting a webinar titled Practicing Equity and Authentic Community Engagement. That's on August the 14th at 1 p.m. Again, we've got the registration link here, and I'll send that out after today's webinar. And then our next Maternal Health Echo is scheduled for August the 21st and will feature Dr. Monique Bethel and Tasha Charles from Wellstar MCG Health. And it's titled Cardio OB, Addressing Cardiac Health for Women in the CSRA. AIM for Safer Birth has released their Season 2 podcasts. They address topics such as community birth, quality improvement, patient engagement, and rural perinatal health. Use the link on the screen to access the podcast. AIM recently released their Maternal Early Warning System Implementation Resource Kit. It's a collection of best practices to aid in the early recognition of changes in pregnant and postpartum patients, vital signs, and clinical conditions. It is intended to support and augment patient safety bundle implementation, and as usual, it follows the 5R framework. It's free to download, and you can use the website or scan the QR code on the screen. And then the American Heart Association has some learning modules that are available online. 2 of the modules align nicely with the CCOC initiative, the role of maternal health in cardiovascular health, and addressing health disparities. You can use the QR codes on the slides to access the learning modules. They're available at no cost to you or your organization. They do provide CMEs and CEs, and these can meet some of our process measures 3, 4, and 5 for your different facilities. So there's the first one, and then the one on addressing health disparities there. Again, I will send these out as a follow-up this afternoon or tomorrow. And then just a quick reminder, on August the 19th, Hope for Georgia Moms, Northeast Georgia Health System Center for Simulation and Innovation, and A1 will be hosting their 3rd session of their obstetric patient safety training. So please take advantage of that and email Tasha Murchison if you're interested or your facility is interested in taking part in that. And before I turn it over to our speaker for today's webinar, just a quick view of the key driver diagram. We always like to show that for our maternal cardiac conditions. It shows our goal to mortality related to maternal cardiac conditions in Georgia. And then our SMART aim is by February the 6th, 2026, to reduce harm related to existing and pregnancy-related cardiac conditions through the 4th trimester by 20%. And then, of course, we have the process and structure measures are embedded into the interventions there. If you need any assistance with the key driver diagram or any of your process or structure measures, feel free to reach out to any of our team, and we can kind of help you walk through or brainstorm some of those. And now, without further delay, I would like to introduce our guest speaker for today's maternal webinar. Please help me give a warm welcome to Dr. Catherine Lindley. Dr. Lindley received her medical degree from Emory University School of Medicine and completed her residency training and cardiology fellowship at Barnes Jewish Hospital in St. Louis. Her clinical and research interests are in women's heart disease and cardioobstetrics, focusing on the heart disease in pregnancy, peripartum cardiomyopathy, contraception in women with heart disease, and cardiovascular sequelae of preeclampsia. Dr. Lindley is an associate professor of medicine and an associate professor of obstetrics and gynecology at Vanderbilt University Medical Center, where she is the Samuel S. Riven Director of the Vanderbilt University Women's Heart Center. She's a clinical investigator specializing in cardioobstetrics. She's the chair-elect of the ACC Reproductive Health and Cardioobstetrics section. Her clinical and research efforts aim to develop multidisciplinary solutions to reducing short and long-term cardiovascular complications of pregnancy in women with congenital and acquired heart disease. Dr. Lindley will speak to us today, addressing the cardiovascular contribution to maternal mortality. Please welcome Dr. Catherine Lindley. And I'm going to turn it over, so give us just a second to transition.
Great. Well, thank you for that. Very nice introduction. I'm very happy to be here today. As you heard, I am an Emory alum. And actually my third child's name is Georgia. You can know that I actually am very excited to be speaking to all of you in Georgia, and am really impressed with all the work that's happening in Georgia for maternal health care. Today, I'm going to be talking to you about the cardiovascular contribution to maternal mortality. I do not have any financial disclosures. I will disclose, number one, that I'm a cardiologist, not an OBGYN, and number two, that I'm very biased to think that this is the best possible work anyone could do and the best possible job. I really do enjoy this work. So our objectives today are going to be to understand the use of common risk stratification schema to identify pregnant patients with high-risk cardiovascular conditions, understand strategies for identifying cardiovascular emergencies in obstetric patients, and understand the importance of team-based care for the pregnant patient with cardiovascular disease. Unfortunately, as I'm sure everyone on this call is aware, maternal mortality has been steadily rising in the United States, and that's in the face of declining maternal mortality in all other major developed countries. Unfortunately, you can see in the dark green there, we have the highest maternal mortality of all major developed countries in the world. And there are substantial demographic disparities when it comes to those maternal health outcomes. And you can see that Black women in the United States actually have a substantially higher risk of maternal mortality when compared to white women in the United States and to all other major developed countries. Georgia has been making really great efforts in improving care for pregnant patients. However, consistent with many of the states in the South, the maternal mortality rate is still very high in Georgia. On the recent Commonwealth Fund state scorecard for women's health, you guys ranked 15th, and unfortunately in Tennessee, we ranked number 1. So I think we all have a lot of work to do together. And it's not just maternal outcomes that are lacking in your state and in my state, but really overall, we're not doing a great job of providing comprehensive health care for women. You can see that in Georgia, some of the main drivers for that include issues on coverage, access, and affordability. The reason that I'm talking to you about this is because, as you probably all know, cardiovascular disease is actually the leading cause of maternal mortality. When you look at cardiovascular disease, oops, my circles are misplaced there. That's supposed to be around cardiomyopathy. When you look at cardiovascular disease and cardiomyopathy together, it counts for about 1/4 of all maternal deaths in the United States. And again, shift all of those one to the left. When we consider other conditions like pulmonary embolism, stroke, and hypertension, which I would very much consider to be cardiovascular conditions, it counts for over half of all maternal deaths in the US. These numbers are very similar. When we look at the data from Georgia, you can see that cardiovascular conditions by far and away was the leading cause of maternal deaths in the most recent state MMRC report from 2019 to 21. I think another very important thing for us to realize is that most people don't die when they're pregnant, but it's rather the postpartum period when we tend to see the highest risk of maternal deaths, and particularly maternal cardiovascular deaths. Although you can see that across all time periods during pregnancy, delivery, and the early to late postpartum, cardiovascular conditions play a major role in the leading causes of death. We can only anticipate that these problems are going to continue to grow over the next several years as there have been changes in access to reproductive care in many states in the United States. There's an anticipated 21% total increase in maternal mortality with recent abortion bans, and that is expected to disproportionately affect Black women, leading to about a 33% increase in total mortality. In addition to those mortality numbers, it's expected to increase poverty and racial and geographic health disparities for women. So the implications are likely far reaching and will likely affect not only pregnancy outcomes, but other health outcomes as well. As you can see on the left side of the screen, much of the Southeast is sort of an abortion desert for patients, and it interestingly lines up pretty consistently with the areas of the country that have the highest levels of maternal mortality. This is particularly important to us because we know that about half of all pregnancies in the United States are unplanned, and the majority of women do not recall discussing pregnancy planning or contraception with their cardiologist, and we don't do a good job of documenting contraception utilization in the medical record. So we can anticipate that there will be quite a large number of women with cardiovascular disease or cardiovascular risk factors who develop unplanned pregnancies who may or may not be able to access pregnancy termination care if indicated. Now, the reason for a lot of these worsening trends that we're seeing in the United States, probably for some of the trends that we're seeing in the Southeast, and also a reason to have alarm with regards to access to pregnancy termination care, is related to the rising burden of chronic cardiovascular risk factors. As you can see, Georgia, just like in Tennessee, has very high rates of underlying obesity, and going along with obesity comes higher risk for hypertension, diabetes, other cardiovascular risk factors, hyperlipidemia, and there's a substantial disparity gap when it comes to risk of having those chronic medical conditions among people who are of higher income and lower income. So we know that our lower income patients in these states with higher levels of obesity are going to have particularly high levels of affliction of diabetes and hypertension, which then increases the risk of adverse cardiovascular outcomes. So kind of when we want to start off in thinking about how we can address this problem, part of the problem is trying to figure out who are the highest risk patients. Those patients who are at higher risk need to be sure that they're having multidisciplinary care by people with expertise in caring for cardiovascular disease in pregnancy. Unfortunately, we know a lot of times this disease or these risk factors are not recognized, which may contribute to delay in receipt of care and lack of coordinated multidisciplinary care. Now, there are several different schema that we can use for assessing cardiovascular risk during pregnancy. There are three major ones that we use, and I honestly utilize all three of them for every single patient and then sort of use the summative result of that to develop my assessment of what their risk of cardiovascular complications are in pregnancy. One of the more frequently used ones is called the CARP-REG2 risk stratification schema. This was developed out of Toronto, which it was a prospective cohort of patients that it was comprised of about 2/3 congenital heart disease, but it did also include some patients with acquired heart disease and cardiac arrhythmias. It was sort of a moderate risk cohort of patients. There wasn't a particularly high number of patients with the very high risk conditions such as pulmonary hypertension, aortopathy, mechanical heart valves. And so in this moderate risk cohort, you can see that about 16% of all of their patients, who were, of course, being managed by an expert cardio-obstetrics team, had a cardiovascular complication of pregnancy. But fortunately, the risk of death was very low at less than 0.5%. Now, the most common complications that these patients experienced were either arrhythmias or heart failure symptoms. And I would say that that's certainly consistent with what I see in my practice. Now, these complications arise at different times during the pregnancy. It's most common during the second and third trimester to have complications related to arrhythmia as the cardiac output is increasing and you're experiencing dilatation of all four chambers of the heart. And so that's commonly when we'll see these arrhythmic complications. On the other side, heart failure more typically occurs in the third trimester or particularly in the early postpartum period. It's during these times that you have a particularly high volume load, rising SVR, systemic vascular resistance, and these things can lead to the development of heart failure in patients who are prone to it. So the way this risk stratification model works is there are 10 weighted predictors, and based on which predictors the patient has, you'll develop an overall risk score. So there are five general predictors, which include things like a history of arrhythmias, New York Heart Association classification. There are 4 lesion-specific predictors, which include things like mechanical heart valve, coronary artery disease, pulmonary hypertension. And then there's one delivery of care predictor, which means that they entered into comprehensive care after 20 weeks of gestation. So you add up their weighted risk score, and then based on what their risk number is, you can see along the left side that it will estimate a risk of cardiovascular complications anywhere between about 5% and 41%, depending on how many of those risk factors they have. Now, another very commonly used risk stratification schema is the Modified World Health Organization risk stratification system. And this doesn't, it's not developed out of a specific cohort of patients, but rather it sort of takes our lesion-specific knowledge about risk with pregnancy and then buckets those patients into sort of low, medium, or high-risk categories. So patients who fall into class 1 are patients with minor abnormalities like a repaired ASD or sinus tachycardia. And these patients have no higher risk of cardiac complications in pregnancy than the general population. Patients who fall into class 2 are people who are expected to have a small increased risk of cardiovascular complications of pregnancy, but they're overall expected to do well and sort of generally get a green light to proceed with pregnancy. And that includes things like most arrhythmias, repaired tetralogy of Fallot, or repaired coarctation of the aorta. Now, patients who fall into class 3 are patients who have a significant increased risk of maternal morbidity and mortality. Pregnancy is not considered to be contraindicated in these patients, but it is known that they're going to be at much higher risk of having cardiovascular complications, and it's recommended that anybody who falls into this category be followed closely with a maternal fetal medicine specialist and a cardiologist who both have expertise in the care of cardiac disease in pregnancy. This includes conditions such as a mechanical heart valve, a systemic right ventricle, people with a single ventricle palliation repair or a Fontan procedure, patients with other complex congenital heart repairs or cyanotic heart disease, and a variety of different aortopathies, basically all of the aortic dilatation diseases with a relatively normal sized aorta. Now, on the flip side, WHO class 4 patients are patients who have such high risk of maternal mortality or severe permanent morbidity that pregnancy is considered a contraindication for them. So for these patients, we should counsel them to avoid pregnancy, and if they do become pregnant, it's recommended that they be offered a termination of pregnancy. Now, of course, sometimes these patients decide to proceed with pregnancy despite those recommendations or have an unplanned pregnancy and then decline termination. And when that happens, then we should just manage these patients throughout pregnancy as though they were a WHO class 3 patient. The patients with these very high risk conditions are those with pulmonary arterial hypertension. Even with modern day pulmonary vasodilators, the risk of death is estimated to be about 25%. And so this is really the highest risk condition you can have during pregnancy. Severe left ventricular systolic dysfunction, so an LVEF or LV ejection fraction of less than 30%, or New York Heart Association class 3 to 4, which means they have symptoms with minimal exertion or at rest. This is also considered to be a contraindication to pregnancy. Patients who've had prior peripartum cardiomyopathy and residual dysfunction of their ventricles, so their ejection fraction is less than 50%. Those patients have about a 20% risk of mortality and about a 50% risk of recurrent heart failure. Patients with severe left-sided obstruction, so severe aortic or mitral stenosis, have very high risk of progressing to heart failure and respiratory failure. It's recommended that those patients also not proceed with pregnancy until their valvular condition has been addressed. And then finally, patients with Marfan or related disorders or bicuspid aortic valves with aortic dilatation, those patients are at an elevated risk of aortic dissection, which can lead to death, stroke, myocardial infarction, need for emergent surgery. So those patients are not recommended to proceed with pregnancy either. Now, what I think is also very important for us to recognize is that pregnancy itself is really a risk factor for cardiovascular complications. Even a perfectly healthy person entering pregnancy still carries an elevated risk of cardiovascular problems compared to when they're not pregnant. We know that pregnancy is a prothrombotic state. There are increased levels of estrogen, progestin, and relaxin. And as a result of these factors, there's an increased risk of aortic and coronary dissection, plaque rupture, stroke, and embolic phenomena. And we know that these abnormalities do not return fully to baseline until about 12 weeks postpartum. So just because the person entered a pregnancy healthy does not mean that we should exclude cardiovascular complications if they're presenting with concerning symptoms. Now, as I mentioned earlier, it's the postpartum time when we tend to see the most pregnancy complications and maternal deaths. And so what I tend to see very frequently is people sort of very closely manage patients throughout the course of pregnancy. And then once they deliver, everyone sort of breathes a sigh of relief, sends the patient home on postpartum day 1, and they have a follow-up appointment 6 weeks later. This is exactly where we get into trouble because we're not out of the weeds after delivery, but rather we're really in the highest risk period for these patients. A lot of the reason for that is related to some of the hemodynamic changes that we expect to see in the postpartum. Patients are the most hypercoagulable during that period, and shortly after delivery, we should expect to see an increase in systemic vascular resistance and a decline in cardiac output. And that combination puts people at very high risk for heart failure, for strokes, for hypertensive complications, for aortic dissections. And so I think it shouldn't surprise us that that first 1 to 2 weeks after delivery is actually the most common time when we see new onset of peripartum cardiomyopathy. The postpartum period is also a common time to see other vascular catastrophes. About 2/3 of all coronary artery dissections occur in the postpartum period, and about 1/4 of all aortic dissections occur in the postpartum period as well. Now, the good news is that maternal mortality is preventable. Across the board, about 2/3 of all maternal deaths are deemed to be preventable when reviewed by state MMRCs. And that includes cardiovascular conditions, which have nationwide about a 68% likelihood of having been prevented. Now, in Georgia, based on your most recent state MMRC review report, it was deemed that about 85% of all deaths in Georgia were thought to be preventable. Now, I think that this is both a little bit sad and distressing when we see that there are so many patients who have died of preventable deaths. But on the flip side, I also see it as an enormous opportunity for us to look at the systems and where we need to make changes so that we can there's actually something we can do. There's a substantial opportunity for us to improve outcomes. When we review the results of state MMRC reviews, we see that there are typically 3 major categories that contribute to these maternal deaths and things that are potentially preventable or fixable. The first of those is related to patient-specific factors, and that includes failure of the patient to recognize their symptoms or chronic medical conditions, particularly including obesity. Now, I want to be the first to say that I am not in any way or shape or form patient blaming here. I think that these patient-related factors are very much dependent on provider and systems of care-related factors. In fact, you can see from the recent state women's health scorecard in Georgia, some of the areas that the state performed the worst on included areas such as reproductive age women going without care because of the cost and very high levels of uninsurance. So of course, when these patients are not able to routinely access healthcare, they're not able to get preconception and interpregnancy care. They're not able to treat their obesity and hypertension and diabetes. And so they go into pregnancies at a higher risk and with less knowledge. ACOG recently, well, it's not really recent anymore. It's been several years now, published this practice bulletin. It's Practice Bulletin 212, and it's looking at cardiovascular disease in pregnancy. And this group identified that there were really four key sort of patient-related factors that related to maternal cardiovascular mortality. That included, first of all, race and ethnicity. As we talked about before, we know that Black women are at a markedly increased risk of maternal morbidity and mortality compared to white patients, likely related to a variety of factors, including systemic racism, poor access to care, and worse chronic medical conditions because of those reasons. Age is another major contributing factor, knowing that women who are over age 40 are at about 30 times the risk of dying compared to those patients who are less than 20 years old. Hypertension is a major contributing factor to maternal deaths, whether that be chronic hypertension or hypertensive disorders of pregnancy. Those patients have about a 13-fold risk of myocardial infarction and about an 8-fold increased risk of heart failure. And finally, obesity. We know that about 60% of all maternal deaths occur in patients who are either overweight or obese. Now, I think it's really important for us to take just a moment to discuss a little bit further that risk factor of hypertension. We know that across the United States, rates of chronic hypertension as well as preeclampsia are steadily increasing, likely related to these sort of increase in chronically poor health and chronic cardiovascular risk factors. While we've made some great progress in treating hypertension in pregnancy through things like initiation of aspirin for preeclampsia prevention and blood pressure management based on the CHAP trial, we know that this remains a major problem. This is particularly an issue in the early postpartum period because we know that based on some of those hemodynamic changes, including increase in systemic vascular resistance and mobilization of third space fluid, we can anticipate that patients' blood pressure is going to increase after they deliver the baby, peaking somewhere between about 3 and 8 days postpartum. This very much correlates with the fact that hypertension is the most common reason for postpartum hospital readmission. It's the most common time when we see heart failure diagnosed. And as you can see on the right side of the screen here, it very strongly correlates with the most common time when we see hemorrhagic strokes as well. There's been some good progress made in thinking about how we can better diagnose and treat this postpartum hypertension. Many institutions have employed remote blood pressure monitoring and telehealth operations, which seem to be particularly helpful for improving postpartum blood pressure management. As you can see here on this slide, this group up at Penn did a study looking at postpartum remote blood pressure monitoring, and they found that utilizing the postpartum remote monitoring not only significantly and completely closed the disparity gap between Black and white patients having postpartum blood pressures measured, but it actually improved postpartum blood pressure management for everybody in the study. Now, the second important thing for us to think about in terms of reducing some of this maternal mortality is related to provider factors. We know that that accounts for about a third of all maternal deaths, and this predominantly includes problems such as failure of the provider to recognize disease, providing ineffective treatment, and failure to refer. And I will say, having sat on state MMRC boards for many years now, this is a very common and recurrent problem that we see. I think the classic example or examples would be patients who come in complaining of shortness of breath and they have a chest x-ray and are diagnosed with atypical pneumonia and sent home with antibiotics when in fact they have heart failure and new onset peripartum cardiomyopathy, and this is either not at all recognized or the diagnosis is delayed, which we know contributes to worse outcomes. Or the other, I think, most common scenarios when postpartum patients present to the emergency room or to their primary provider with severe range blood pressures in the postpartum, and no one recognizes this as an obstetric emergency, and they then have a complication of that hypertension, which may be stroke or seizure or aortic dissection. So I think those are some of the common failure to recognize and provide appropriate treatment and refer to the appropriate providers. Now, we shouldn't be particularly surprised by this problem. We did a study of the American College of Cardiology membership a couple of years ago, looking at cardiologists' knowledge bank and comfort with managing pregnant patients. And as you can see here, a large majority of faculty, physicians, fellows in training, and cardiovascular team members, advanced practice providers had were not at all confident in the management of common medical problems in pregnant patients. When we kind of break that down, so red means a bigger gap and blue means a smaller gap, you can see that some of the most common problems that cardiologists manage in non-pregnant patients, such as acute coronary syndrome, aortopathies, cardiovascular medications, valvular heart disease, there were really substantial knowledge gaps between their comfort in managing these problems in a pregnant patient versus a non-pregnant patient. But I also want to point out that some of these conditions that there appears to be a small gap, such as managing complex congenital heart disease or talking about contraception, are actually not because these providers feel so comfortable managing these problems in pregnancy, but rather just because they don't feel confident managing these problems in anyone. So certainly increasing the confidence of cardiologists in understanding and discussing contraception is going to be a incredibly important thing for us to do. I was very fortunate to be a part of a recent ACOG, an ACOG toolkit development team, which was really designed for helping people identify cardiovascular obstetric complications in non-obstetric settings. So this is primarily focused on the emergency room, EMTs, primary care physician offices, people who aren't used to taking care of pregnant patients, because that's usually where these patients are actually initially going to present. And so as you can see here, if you are interested in reading more about this or implementing it in your institution, you can download all of it for free off of the ACOG website. And I was only a small part of this, so really hats off to ACOG for developing this. And so it really starts with actually just having healthcare providers think about whether or not their patient is pregnant or has recently been pregnant in the last year, because oftentimes if someone is 4 weeks postpartum, the provider might not even think to consider cardiovascular complications of pregnancy because they don't realize that the patient's recently had a baby. And if the patient does fall into that category of being pregnant or recently postpartum, then we want to prompt those providers to think about what are the leading causes of death in this population, much of which are cardiovascular conditions, so that we can really sort of refine our differential and kind of change the lens through which we see this patient, how we're going to deliver their care. And then based off of their symptoms, they have developed clinical algorithms and protocols that can help us identify and treat patients with an obstetric emergency. So there are 3 algorithms that were developed. One was for cardiovascular disease, one was for hypertension, and the other was for eclampsia. So I think that this cardiovascular algorithm is particularly helpful. Kind of the first step after recognizing that the patient has recently been pregnant or is pregnant is to really zone into those red flags for cardiovascular disease. So a lot of times these things may be missed or may be misinterpreted as being non-cardiovascular complications. So for example, wheezing or crackles in the lung exam is oftentimes misdiagnosed as asthma or as pneumonia, but we need to recognize that this is something that we need to think about as potentially being related to pulmonary edema or an acute cardiovascular complication. It's also important that we recognize what is and is not a normal vital sign for these patients. And if their vital signs fall out of that range, we need to be really thoughtful about whether or not there's a cardiovascular reason why they're experiencing these abnormal vital signs. If they do have any of these red flags, which some of which may be common in pregnancy, such as edema and shortness of breath, but some of which are not really present in pregnancy, like a new cough or true paroxysmal nocturnal dyspnea, in particular if they have exam findings such as elevated neck veins, then that should really prompt us to think about cardiovascular conditions. If we are concerned about a cardiovascular condition in these patients, then it's recommended these patients all receive a basic workup that includes an EKG, a BNP level, a chest x-ray, and a troponin. And then based off of those findings, if anything is abnormal, that should prompt us to consult cardiology and maternal fetal medicine, as well as to obtain an echocardiogram. Now, one thing that I see frequently happen is these patients come in with shortness of breath and they have an abnormal chest x-ray, but nobody checks a BNP level on them. Or if they do check a BNP level, it's elevated and that elevation is just attributed to preeclampsia, rather than considering that this might actually be representative of peripartum cardiomyopathy. So it's important that we follow up with appropriate consultation and subsequent testing so that we can rule out serious things or identify them if they are present. Finally, we want to employ treatment that is going to really optimize health for mom. We, of course, always want to be thoughtful about medication safety with lactation and during pregnancy, but it's important that we always prioritize mom's health because by doing so, that's also going to give us the best possible outcome for the baby. So, for example, if mom is in ventricular tachycardia, it would still be appropriate to give that patient amiodarone because she's in a life-threatening cardiac condition, and the risk of not treating her is much higher than the risk of actually treating her. Based upon my recent comments about BNP, I just wanted to comment a little bit further on that. Cardiac biomarkers, including troponin and BNP, are particularly helpful during pregnancy and the postpartum period. We certainly do not recommend that we routinely check them in every single patient, but it is particularly useful if we're concerned about potential cardiovascular symptoms in a pregnant or postpartum patient, or patients who we know to be at risk for developing heart failure, such as patients with congenital heart disease or cardiomyopathies. We can oftentimes help trend these to help understand whether or not they're decompensating. And an abnormal value should always lead to subsequent follow-up with further assessment of their cardiac function. Hold on, my light just switched off. Oh, there, I got it back on. Okay. I'm not going to go through this one on hypertension because I suspect that most of you on this call are very familiar with diagnosis and treatment of hypertension, but there's also a very nice algorithm here that goes through what non-obstetric physicians and advanced practice providers should be thinking about in terms of recognizing severe range blood pressures, how long these patients should be monitored, when they need to pull the trigger to get obstetrics involved in their care. Now, the final area of improvement comes to delivery of care. We know that some of the major contributions to maternal deaths include lack of communication between providers and barriers to coordination of care. And as a result of this, really all major societies, including the American College of Cardiology, ACOG, SMFM, have really all agreed upon and coalesced around this concept of a cardio-obstetrics team or a pregnancy heart team. And this team doesn't just include a cardiologist and an MFM. This also includes their primary care provider, the patient's primary obstetrician, nurses, social workers, pharmacists, the NICU team. It's really about developing a multidisciplinary team that can kind of put the patient's well-being in the center and can communicate together to coordinate and deliver care that really begins before the patient even becomes pregnant and then extends beyond the postpartum period. So I think it's really valuable for us to think about this as a team sport. This means not only all the different disciplines within a hospital system, but across our region and across our state. We should really be communicating with one another and relying on one another to make sure all of our patients are getting the appropriate providers so that we can provide advice or input or elevated levels of care for the patient that require these things. One, I think, important component to this coordination of care comes to our adult congenital heart disease patients. Ideally, these patients would be followed by pediatric cardiology throughout childhood, then transition to an adult congenital cardiologist who would then provide contraception counseling and pregnancy counseling and help guide them through pregnancy into the postpartum period. Unfortunately, we know about 2/3 of patients have a significant lapse in care, meaning 3 years or more between their childhood cardiologist and meeting with an adult congenital cardiologist. And pregnancy is the reason for return to care for about 12% of these patients, which is a pretty significant number and a pretty common reason for return to care. So it is particularly important that these patients have lifelong congenital heart disease care and are really plugged in with an adult congenital heart disease provider even before they become pregnant so that we can optimize them before the pregnancy. Now, when we're thinking about who needs to be a part of that team and what kind of treatment and monitoring they need, it's not the same for every patient. So patients who fall into that WHO class 1 group or a lower risk, their primary OBGYN, cardiologist, and primary care physician are perfectly capable of managing that patient through pregnancy. However, our patients who fall into that WHO class 3 to 4 category, really 2 through 4, should really probably be referred to a center that has a cardiologist and an MFM who have expertise in the care of these patients throughout pregnancy. And they should ideally have a team that also includes anesthesiologists and nursing and social workers so that they can provide a higher level of care when needed. Patients all need to be monitored throughout the course of pregnancy for their cardiac function, and this might include serial BNP testing, serial echocardiograms, and it may also include fetal echocardiogram for patients with congenital heart disease. Importantly, this multidisciplinary team will be able to assess this patient's risk and determine also their delivery planning, including the location, the timing, and the mode of delivery. We know that cesarean birth is a strong risk factor for maternal mortality. It's highly linked to increased risk of bleeding, infections, and thrombosis, and is also associated with increased risk for future pregnancies. Unfortunately, here in the South, we have a very high rate of low-risk cesarean births, and I particularly commonly see patients who are very safe for a vaginal delivery to be recommended a cesarean delivery for cardiac indications. I did a recent editorial with one of my colleagues in Indiana that was based off of a recent study looking at heart failure patients, which really identified that we should be letting the vast majority of our patients have a vaginal delivery, which is typically going to be safest for both mom and baby. I have to say, I'm really proud of the cardio obstetrics team that we've built here at Vanderbilt. And as you can see, it's not just myself and one of my MFMs, but really a cadre of cardiologists and OBGYNs who provide different aspects of cardiovascular and obstetric care. It includes a neurologist with expertise in this space, cardiac and obstetric anesthesiologists, our pediatric colleagues for our fetal care patients, and then very importantly, if not most importantly, our support services, including our nutrition counselor, our geneticist, our patient navigator, our nurses, and our social worker. Now, I can't give any talk essentially without briefly talking on contraception. Really, an ounce of prevention is the most important thing we can do. When we have high-risk patients who do not desire pregnancy, helping them identify a safe and effective method of contraception goes a very long way. So then they aren't faced with difficult decisions with unplanned pregnancies that are putting their life or morbidity at risk. We recently wrote an article a couple years ago talking entirely about contraception in patients with cardiovascular conditions. And really the long and short of it is that long-acting reversible contraceptives and permanent contraception are safe and effective for every single cardiovascular patient, as well as the most effective. So if your patient is interested in a IUD or a subdermal implant or permanent contraception, I recommend that for every single patient. If they're not interested in that, then we would think more about those tier 2 options, including the pill, the patch, and the ring, and the shot. However, it's important to recognize that patients who have increased risk for thromboembolism, we generally recommend avoid estrogen-containing methods of contraception. And then finally, we do not recommend barrier methods alone for patients with significant cardiovascular disease because of the high risk of method failure. So to conclude, maternal morbidity and mortality are actually preventable. But in order to do that, it's going to require a lot of systems changes that include improving access to care, increasing provider education, and increasing collaborative care amongst between institutions and between disciplines. So that's all I have. I very much appreciate your attention, and I am happy to take any questions you may have.
Wonderful presentation. Thank you, Dr. Lindley, so much for joining us today and for presenting. It's all very, very good information. If anyone would like to ask any questions, feel free to come off mute, or you can type them into a chat and we can read those out for Dr. Lindley. I think there's some very, very good information there. And again, I'll share the ACOG link to the resources and the different things that were provided in the presentation with the follow-up email, so you can utilize those in your facilities as you're communicating with your teams, with your providers, building your teams, things of that nature. Let's see, we've got a couple of comments. Dr. Cocky said, "That was great. Thank you. Your team was inspiring." And then we have one from Mary Lou. "How do you manage care for teenagers with cardiovascular risks that are under 18 or with severe hypertension?"
So this is a really important question. And I will say that there are a lot of places that handle this problem very poorly. This is obviously not, I mean, it's not a common situation, but it's also not rare. I am entirely comfortable taking care of any patient who is what I say adult size. Like if I don't have to use a calculator to do weight-based dosing for their medications, I just treat them. I mean, obviously there are social aspects of managing an adolescent that are different managing adult, but I think from a medical perspective, I'm very comfortable managing them. I think that we as adult providers should be comfortable and should, without question, take care of these patients. The problem that I see come up oftentimes is adult providers decline to take care of the patient because they're under 18, or refuse to admit them to their ICU because they're under 18 or to their floor. On the flip side, the pediatric groups are not comfortable with managing pregnancy, and they also don't want to take care of these patients. And then you'll end up with a really sick patient that nobody wants to take care of. We're all here to take care of the patient, and that's what the approach should be. I have never had any legal implications of taking care of a minor, and I think that we're the people who are the best trained to take care of a pregnant minor, and we should be taking care of them.
Thank you. Another question from Lynn Hall. It says, "Great presentation. What about sharing with non-delivery hospitals who will possibly take care of postpartum cardiac women?"
Can you clarify the question, like sharing care with them or sharing information with them?
Lynn, would you like to come off mute and give a little more details or?
Yeah, I just know that a lot of women don't go back to the same hospital that they deliver, and I think it's important to share all of this information really with ERs, especially who will see these women, because when we look at mortality, sometimes the ERs are not treating the women correctly. So it could, I don't know if they're going back to the same hospital or not. But that was just my thought.
Yeah, no, I agree with you entirely, Lynn. The goal of and I know there's several other, like, also very well done sort of protocols and toolkits for addressing this problem. And I imagine that I hope that they all have the same goals, but I know that the goal of the ACOG toolkit was that this be given to everybody who will see reproductive age patients, because you're exactly right. My patient who's gotten care with me throughout the whole pregnancy but lives 2 hours away, when she has an emergency, she's going to go to the local ER, and that person may well not recognize her condition. So I think number one, especially emergency rooms, cardiologists, and primary care providers in rural areas or non-delivering hospitals must be educated on this, because that's really the gateway to care for these high-risk patients. Number two, I spent a lot of time educating my patients on sort of red flag signs and symptoms, normal blood pressures. I see every single one of my patients by telehealth 1 week postpartum, and they all have a blood pressure cuff. So I want them to be able to recognize and advocate for themselves when they are developing a problem. And we're doing that very quick check-in with them so that I can make sure their blood pressure is at goal. I can screen them for cardiovascular symptoms. And then if we need to make changes or get them admitted, hopefully we can sort of be ahead of the game rather than behind.
And Dr. Bird, who is she's one of our leaders for our GAPQC on the maternal side, and she says we are connecting and engaging ED providers to conduct screening. And then she has a project where she has provided education to all 6 of Georgia's residency programs, providing the CBD risk assessment screening and signs and symptoms warning signs. So we're working on that. It has been a challenge here in Georgia to get in and engage the emergency departments, especially in the rural areas as well as the non-delivering providers. But it is something that we are working on and tackling in baby steps.
Yeah, I mean, I think that's great that you're doing the work. I don't think that there's any state that's like can like claim a gold medal on that. It's a very big task, and we see it as being very important. Not that the emergency services don't see it as important, but like it just doesn't come up with them that often, and so it's not. I think it's just not as high on the radar. So it's there's a lot of work to be done there. I think most people want to do the right thing and want to employ these things, but there's a lot of ERs and there's a lot of education to do.
Agreed. Any other questions before we wrap up for today for Dr. Lindley, or any comments at all? Again, thank you so much, Dr. Lindley. I know you have a very busy schedule, tight schedule, and we appreciate you taking time out for us and sharing your experiences and expertise. Again, we will place the webinar on our website as well as the DPH YouTube channel in the coming days. Any resources that were shared in the PowerPoints, we'll send that out in a follow-up email to you to use as a resource and tools as you're doing your quality improvement work. So thank you for joining us again today. Please make plans to join us on September the 3rd for our next GAP maternal webinar, and have a wonderful rest of your day.
Great. Thank you, everyone.
Appreciate you
Take care.
all. Thanks
for the work you're doing.